Thank you to everyone who's already here. We're going to start in just a couple of minutes, so just sit tight, but thank you for joining early. Hey, Sarah.
Hi there.
Okay, I mean, it's 11 o'clock and people are here, so I think we'll just get right into it. So, hi everyone, welcome to our open enrollment and compliance webinar. We're thrilled to have all of you here with us today as we dive into the critical aspects of maintaining a compliant and successful benefit program for your employees. So, my name is Alyssa and I'm the sales development rep at Benecurve. So, my role involves reaching out to you all, offering human resources and benefit teams valuable insights, and just to promote Benecurve. And our goal is to establish trust and credibility with you all. And as your needs evolve, perhaps you'd consider partnering with us around the design, administration, management, and compliance of your employer sponsored benefits plans. Our team of industry experts has prepared a comprehensive session for today that covers a range of important topics, and Sarah Borders will be conducting today's discussion. Managing your organization's benefits program effectively during open enrollment can be a challenging yet crucial endeavor. It's not just about providing choices to your employees, but also ensuring that your offerings align with ever evolving regulations and industry standards. During this webinar, we will provide you with insights and practical guidance on navigating through those intricacies of open enrollment and compliance. We'll address key compliance issues that are crucial for ensuring the best for both your organization and your employees. We encourage active participation throughout the webinar. As you can see on the right-hand side, you can actively write questions throughout the webinar, and they will be addressed either as we go or reviewed in the dedicated time at the end for Q&A. So feel free to ask live as we go. Now, without further ado, I'll hand it over to Sarah, who is our seasoned compliance professional. So, Sarah, the floor is yours.
Thank you, Alyssa. Good morning, everyone. Good afternoon, depending on where you are. Today, we are going to review open enrollment and compliance and some best practices for employers who sponsor a group health plan. So, I am Sarah Borders, and we work closely with Benecurve, and maybe we've even spoken with some of you in the past. And we want to make sure that you're set up for success because most plans do actually renew around January 1st, maybe even December 1st. Not every plan, but we want to make sure that you have some things to think through and plan for, especially as it relates to the typical things that can get missed during the open enrollment season. So today we're going to talk about compliance requirements, namely under the CAA and transparency and coverage rules. So these are brand new rules, and perhaps you might even sort of heard of this or are curious or concerned about the CAA and the new requirements under this particular rule. Then we'll go through some additional 2023 updates with regard to ongoing requirements that have been around for many years and some updates that you can plan for. And then we'll go through a couple of best practices to make sure that you have a checklist of sorts to go through before open enrollment or really during your open enrollment planning sessions. Then we'll have time for Q&A. And yes, as Alyssa said, please type your questions into the chat and we will definitely have time for any questions that you may have. So let's first touch on the new requirements under the CAA. So the CAA stands for Consolidated Appropriations Act of 2021. And this was a very wide sweeping law that was passed under the Trump administration as soon as the Biden administration sort of took over. So we've had this rule for a couple of years now, and now it is really starting to sort of proceed. And the way this typically works is that we have a law that's passed, legislation is passed, and then the departments, Department of Labor, Department of Health and Human Services, or Department of Treasury and IRS are directed to tell us how to comply. So they write regulations to comply with the particular law. So a lot of times when we get a piece of legislation, we do not know exactly how we're supposed to comply with a particular requirement. We just know that it's coming. And sometimes even the dates are not quite clear. So now what we're seeing is the fallout from this piece of legislation that was passed several years ago in the form of regulations. And that is going to directly relate to what you have to do as the employer and perhaps what your vendors, your carriers, your different TPAs are going to assist with. So we want to arm you with what you need to know to be able to ask and put your hands on or your finger on how they're going to assist you and then what it is you may have to be doing. So under the CAA, there are many rules, and I'm going to go through some of those in just a moment. But one of the rules is the requirement for contracts with your TPAs and your pharmacy benefit managers and your providers networks cannot contain within those contracts things that could be construed as a gag clause. And so I'll show you in just a moment an example of a gag clause, but overall contracts cannot contain these provisions that essentially say, we as the plan sponsor, we can't access our data, our provider specific data through the network or through the TPA that we work. That data can no longer be restricted, and there can't be any provisions in your contracts with your carriers or TPAs that have these types of provisions. And so that is number one. We can't have these types of contract provisions. Now, though, and this has been around for a couple of years, the requirement not to have any of these gag clauses, but now we have to actually show our work essentially. And that is going to take the form of a affirmative attestation that has to be actually submitted directly to CMS. And so what does that mean exactly? Well, by December 31st, so by New Year's Eve this year, the year that we're in right now, either the employer or the insurance company will need to submit a gag clause prohibition compliance attestation. And you're going to see this acronym here, GCPCA. That's what it stands for, Gag Clause Compliance Prohibition Attestation. This attestation has to be submitted to CMS via their web portal, which you can see linked on the very last bullet below, no later than December 31st, 2023. So in a few short months. Now, who would be exempt? This would include accepted benefits such as standalone dental or vision, health FSAs, HRAs, HSAs, and if any of you out there currently are looking at providing an individual coverage HRA. Those are pretty rare, but sometimes we do have employers that adopt those. So this applies to every type of group health plan. So if you're a small group, if you're a large group, if you have a fully insured plan, if you have a self-insured plan, if you have what's called a level funded product, this applies to you. It just becomes a matter of who is doing this, really. We can tell mostly by some responses at this point who is going to, in fact, be doing what in this situation. So if you have a fully insured plan, so for example, if you buy a United Healthcare plan or Blue Cross or Anthem or Care First or Kaiser or any type of group insurance product from an insurance carrier, whether a large national carrier like Aetna or Cigna, or you have a more local regional type of carrier and your plan is fully insured, then overall, what we're seeing is that the carriers, the insurance companies, are submitting this attestation on behalf of their entire book of business because they have those contracts with the networks. That is not always the case. There have been very rare instances where we're seeing that even fully insured plans will sort of confirm with their employer groups that buy their insurance that they don't have any gag clauses, but the employer is still required to take one step further and go onto the CMS website again that you see linked below and make sure that the attestation is actually uploaded or it's actually submitted via the web portal. So this will take confirmation to your carrier to see who is doing what. Now, if you're self-insured, maybe you have a third-party administrator that administers claims, but you self-fund all of the claims and you have stop-loss insurance and maybe carved out pharmacy or maybe even carved out mental health benefits, then this is definitely going to require some steps by the employer. The steps would be going again onto the GCPCA webpage, again linked below on the last bullet, and submitting your attestations that your contracts contain no gag clauses. So this is relatively simple to do. It does not take a lot of setup through this portal. If you'll recall, last year we were dealing with something called the RxDC, the Prescription Drug and Healthcare Reporting, that was due for the first time in late January, and then again in June 1st, which I am going to touch on in just a moment. But this gag clause compliance attestation is different, and it's not quite as difficult as the RxDC was, for sure. So you'll want to confirm with your vendors, your TPAs, carriers, and other types of third-party administrators that you might utilize and ask them how they intend to assist with the gag clause prohibition compliance attestation. And they may tell you, they may send you something that says our contracts contain no gag clauses, but you'll want to make sure that they aren't telling you that they're actually going to submit the attestation on your behalf. That can get missed. I've been noticing that. So again, confirm with your carriers, your vendors, your partners, how they will assist, if what level they'll assist, and if you have to take the next step and actually attest on this particular web page through CMS. There's no other way to really do this. You may say, well, what if we don't do this? Well, there's no specific penalty announced really for anything under the CAA, except that it may be subject to enforcement action. So that may come in the form of a Department of Labor investigation where they found that your contract did in fact contain gag clauses, or perhaps that the contracts didn't, but there was no attestation submitted. So you'll want to just make sure that this is documented and performed, because it's relatively simple in the activity that you may have to do. So hopefully this is something that you've already heard of before, but it's something that we are working with Benecurve clients to make sure is happening and staying on top of those different vendor partners. So here's an example of a gag clause, just so you can kind of conceptualize what this might look like. And overall, most third-party administrators contract with networks. They contract with networks of providers, networks of different hospitals and clinics and doctors' offices, facilities, in other words, and also have contracts with pharmacy benefit managers as well. So a gag clause, and this is taken straight from the regulation, may look something like this. The employer-sponsored group health plan that's administered by a TPA, third-party administrator, and the contract for reimbursement between the group health plan that's facilitated by this type of TPA states that the plan will pay providers at rates designated as point of service rates, and this is common. Then the TPA considers those rates to be proprietary, so it includes language in their contract that basically states that the group health plan agrees not to disclose the point of service rates to plan participants. This is a gag clause because we're supposed to be able to see this type of data. Now, it can restrict in the contract that the plan itself or the carrier itself doesn't publicly disclose this information, because that would be considered proprietary. But for the individual plan or the plan participants, there can't be any such language that restricts them from receiving the provider specific data points or cost of care services. So overall, this is what it should look like. And if you have contracts with your TPAs, a lot of times it doesn't even say anything about this. You may want to start requesting your contracts to see, I need something to review in order to be compliant with the CAA and this requirement for no gag clauses in our contract. You have to see the contracts to know for sure. There are some other transparency and coverage and CAA requirements. And the reason why these two terms, transparency and coverage and CAA, get blended together is because they're so similar in the sort of methodologies and the overall reasons for having these rules in the first place, which is really the point of having these rules is so that plan sponsors, employer plan sponsors that sponsor a group medical plan specifically and other benefits, are aware that they have fiduciary duties to monitor the costs of their plan and also to monitor their service providers. And so if you think about kind of the way this is typically gone, most employers kind of don't really know the costs of their plan unless maybe you're very kind of self-insured and you're a little more sophisticated and have taken the steps to do that. But overall, we don't really know very much about the cost of care through our group health plan. And so the rules are actually taking the way to get to it by saying, employers, you have a fiduciary duty to know the cost of your plan, to assess whether this is benefiting your plan participants. Is this cost too exorbitant? Should we be looking at other vendors? Are they helping us handle our compliance responsibilities? So it's really kind of forcing the employer to take on their fiduciary duty to know what the costs of the plan are. And this is supposed to sort of open up the box and be more transparent so that people know the costs of their health insurance, like the actual costs of that health care that the health insurance is paying for. So if you think about your retirement plan, if you offer some sort of retirement plan, you know probably already there's a fiduciary duty to monitor those service providers. And so the same rules apply under ERISA, this rule that kind of dictates pension funds, retirement plans, and group health plans. So you'll have to really change your mindset that we're sponsoring a group health plan. It's covered by ERISA, and therefore we have a lot of duties to make sure that we understand what's going on within our plan and make changes as necessary. So that's where this stems from. So hopefully that kind of helps you understand why this is still falling in your lap to have to do these things, and it's not just pushed off on the carrier. So a couple of the other requirements that I'll just review quickly. RxDC reporting. This, in other words, is the healthcare and drug spending reporting that was supposed to be submitted to CMS. The first round was due in late December. They pushed it to January, the end of January last year. And the second round was due by June 1st. And every year thereafter, it's going to be due to CMS in the same format by June 1st. So if you'll recall, this was the D1, the D2, and the D through D8. This was kind of these different data sets that had to be uploaded to CMS through their HIOS portal. And so this is going to come back around again. And so this is something you're going to need to plan for in early Q1, which we'll do subsequent webinars all about RxDC. But just know that this is something that we have to deal with every year. Just like ACA reporting or 5500 filing, this is something we have to do, or a service provider will have to do on our behalf each year. The price comparison tool, which is pretty much going to have to be done by a third-party administrator or carrier. All of the services must be available in an internet-based self-service searchable tool by January 1st, or when your plan renews in the 2024 plan year. This is, again, largely reliant on an insurance company or a TPA, but we want to, again, confirm with our service providers that all of these things are happening. And if not, how do we get it fixed? How do we get it done? The air ambulance cost data, this has actually been delayed pending further rulemaking. And so if we did see regulations that were issued in 2023 on this, then this essentially means that the air ambulance cost data would be due to CMS for 2 years, and that would start in 2025 and 2026, that it would actually be due. More to come once these rules are actually issued. Machine readable files, these were supposed to be available publicly on a public facing website so that developers could download this information, or even the government could assess this information. This is not to be read by individual employees. This is, like it says in the name, machine readable files. Big, huge data files were supposed to be available publicly through either your medical claims TPA again, or through your carrier. So this came about last year, the enforcement of it, July 1st, 2022. So we're already over a year into this requirement. Advanced EOBs, these are pending further rulemaking. At some point, we're going to have to, or the plan is going to have to issue advanced EOBs in advance of, like it says in the name again, advance of some sort of type of treatment or surgery, or some kind of cost of care estimate that is provided to the participants prior to receiving care. But more to come on how we're supposed to comply with this in the future. The No Surprises Act, one thing to mention here, this is the rule, this is the piece of the CAA that deals with balance billing and the prohibition on individuals receiving a balance bill for certain types of claims. So that would be emergency visits. That would include things like radiology, anesthesiology in an in-network provider setting. So if they're in an in-network hospital with an in-network physician doing the surgery, they can't have out-of-network providers coming and balance billing them. So it pertains to certain types of claims that are no longer allowed to impose balance billing on individuals as it was in the past. The thing to note here is that employers are required to give out a notice of this No Surprises Act prohibition. And if the TPA or medical carrier provides this notice on their public-facing website, which most of them do, then the employer isn't necessarily required to give out an additional notice. But most do, just because it's a good thing. It's a good best practice. There's no reason that really wouldn't include your No Surprises Act notice within all of the other notifications that you give. And as I mentioned before, the prohibition on gag clauses, again, that attestation is due no later than this year, December 31st, 2023, and each December 31st, every single year thereafter. Turning to some more ongoing updates, things that have been around for many years, I wanted to highlight, because you're going into likely open enrollment planning and making sure that your plan has certain limits in place, that your enrollment guides have certain limits reflected, that your enrollment systems, if you use any type of online system to enroll employees, you want to make sure that all of the numbers are updated and that you have everything correct in your plan materials. So the new limits were announced for high deductible health plans for the out-of-pocket maximums, as well as the minimum deductible that a high deductible health plan can have. Also, the HSA contribution limits for self and family coverage and the catch-up contribution were given cost of living adjustments. So, for example, if you have a high deductible health plan, then the out-of-pocket, that includes the deductible goes towards the maximum out-of-pocket. It cannot be any more than $8,050 or $16,100 for a 2024 high deductible health plan coverage. And the deductible itself cannot be any lower than $1,600 or $3,200 for family. Most high deductible health plans have a much higher deductible, but this is as low as it can go. So that's the ceiling and the floor. Now, if you provide a high deductible health plan and employees can contribute to an HSA, which is really the point of offering a high deductible health plan, then there's a limit to how much they can put into their HSA for the tax year. So this relates to the tax year, not necessarily your plan year. So for example, if you renew February 1st, you have a high deductible health plan, the employees can contribute a maximum of $41.50 for the entire 2024 tax year, as long as they're enrolled in high deductible health plan coverage at the same time. If they have any sort of disqualifying coverage, such as Medicare, Medicaid, TRICARE, CHIP, if they're on their spouse's plan, maybe have dual coverage, if they have any sort of disqualifying coverage that pays benefits before that minimum deductible of either $1,600 or $3,200, then it disqualifies them completely from putting in any HSA contributions for that month in which they're enrolled in disqualifying coverage. So you have to remember that if you're going to sponsor a high deductible health plan and help facilitate this HSA, maybe you make HSA contributions, maybe match or put in a flat dollar amount, then any sort of coverage that you offer, you want to make sure that they're not enrolled in any disqualifying coverage that you also offer. This typically comes up in the context of having a health FSA or a general purpose HRA. So for example, let's say that my employer provides an HSA high deductible health plan option, but perhaps my spouse has a health FSA on the other side. That makes me, as the individual taxpayer, disqualified from putting any funds into my HSA because I have disqualifying coverage. I can receive benefits just by very nature of being a spouse of a person with health FSA. So the way that employers typically combat this is to offer what we call a limited purpose or HSA eligible FSA or HRA, so that it pays benefits after that $1,600 or $3,200, so that it doesn't disqualify individuals from their HSA. So if you have any other questions about how HSAs work, I don't want to take too much time explaining them, but overall, that you'll have to remember there are other things that disqualify individuals from HSAs. And so they are individual bank accounts, they're individual taxpayer accounts that they own, and they can take their funds with them once those funds have been deposited. FSAs and HRAs are different. They're employer sponsored plans. They're substantiated by the employer or a third party that you hire. And overall, the employer has much more control over those funds, rather than an HSA that is really actually an individual's bank account. It's their health savings account. So you just have to keep that in mind when we're offering these types of products, that certain things cause individuals to be ineligible. And lastly, if you are one of the 0.1% of employers that actually offer an accepted benefit HRA, then the annual contribution limit went up to $2,100. But again, that is so rare. I don't think I've ever seen an employer adopt one of these. But if you do, then that ability to contribute more has gone up for 2024. Also, we are coming in on another requirement that comes around every single year, and that is to distribute your Medicare Part D credible or non-credible coverage notices to all of those who are enrolled in Medicare or seeking to enroll in Medicare. So this would really be easier to give the notice to all of your employees, because we don't really know if somebody's seeking to enroll in Medicare, because for one, their spouse could be seeking to enroll in Medicare. You wouldn't know that. And there's other reasons besides turning age 65 that you can take Medicare. There is ESRD Medicare and disability-based Medicare that individuals could be seeking to enroll in. So it's just easier to send the Part D notice to all of your employees. This applies to all group health plans. So whether you're very small or very large, fully insured, self-funded, doesn't matter. The Part D notice is required to be distributed to really all plan participants. So you'll want to check with your insurance carrier or TPA for if your plan itself is actually creditable or non-creditable. And what does that mean exactly? What does creditable mean? It means that your health plan's prescription drug benefit pays as good as or better than Medicare Part D's prescription benefits. And so this is an actuarial formula, and it's almost impossible to sort of look at it at your plan design and know, oh yes, our coverage is credible or not. I will say most plans are creditable, but sometimes, not always, high deductible health plans can be deemed non-creditable. That would have to be given to your employees so that they can know, should I take Part D at this point, or should I delay Part D in favor of my group health plan? And that can have an impact on the cost of their Part D coverage in the future, should they delay Medicare. So again, if your insurance carrier does not provide you with the credible coverage status, then an actuary is what you're supposed to use. However, there's a tool that United Healthcare has issued, even if you're not with United Healthcare, that can be used as a last resort to kind of understand, yes, the coverage we think is in fact creditable or not creditable. And that's something we can assist with if you have any other questions on it. But you must distribute this notice before October 15th, even if it's sort of included in your plan materials and your open enrollment time is like the end of October. You'll really want to send this separately to your plan participants before October 15th. You can send it via email if employees can receive email, electronic disclosure rules, or you can mail it to them or give it to them in a manner that they should be able to receive it. So sometimes I hear employers putting it with paycheck stubs and other kind of creative ways to get this to the employees. But just remember this deadline, October 15th, which is fast approaching. We're already in October 4th, which is hard to believe. This is going to be something that every single group health plan, everybody on the phone today is going to have to do. The insurance company does not do it for you. They may tell you the status, but they're not going to send this to your employees. That does not happen. So make sure that this is on your to-do. Okay, so the next thing that was updated that I want to mention that goes directly into open enrollment planning is the ACA's affordability and safe harbors that you will use. So if you are an applicable large employer, in other words, you're what we would call an ALE, applicable large employer, one who has 50 or more full-time employees plus equivalents, which are essentially part-time hours that translate into full-time bodies. There's a calculation for that. If you think you're hovering around this 50 mark and you have a handful of part-time employees, then it's time to really start paying attention to the employer mandate rules under the Affordable Care Act, because they apply to you whether you know it or not. So if you are an applicable large employer, you need to get clear on if your coverage, the amount that the employees have to pay in their insurance premiums for the lowest cost plan, is actually what is considered affordable. The affordability percentage changes each year based on cost of living adjustments. So you may remember that in the first few years, it was 9.5%. It had to be at least 9.5% of either their rate of pay, their W-2, or federal poverty level, meaning the contributions that they pay. Now, this year, it has decreased significantly to 8.39%. So it's substantially lower than it was in prior years. Last year, it was 9.12%. And the year before that, I believe it was 9.86%. So it changes each year. And now we're all the way down to 8.39%. So what does that lower percentage actually mean in practice? Well, it means that the employee's contribution will be less, and the employer's contribution may need to be more than it was in prior years. And I will give you some examples to help illustrate how this works. So if you are subject to the employer mandate, you have to use and identify one type of safe harbor that you can say, our coverage is affordable and this is the method we're going to use, or this is the number we're going to use. And it has to be the same for all of your employees in a particular class. So you can't use W-2 for one employee and rate of pay for another. You have to use the same method across the board. So the Form W-2 method essentially looks at the Box 1 income of the employee, and it essentially says, is our coverage, again, 8.39% or less of the employee's Box 1 income, again, in a monthly format, so divided by 12. It is a little bit difficult to know how much an employee's Box 1 income is, because if you think about it, if we're planning for the 2024 plan year, January 1st, 2024, And we're going to say that our coverage is at least 8.39% of the employee's Box 1 income for that same year, then we would not know the 2024 Box 1 income until early 2025. So you have to think about the fact that we're not talking about last year's Box 1 income. We're talking about this year, the 2024 Box 1 income, which again is retrospective in application, because again, we don't know the true Box 1 income until 12 months later, essentially after our contributions have already been set. So the reason that employers would use this one is because it can yield the highest employee contribution. So if you're right there on that line and you're keeping costs just very tight, and what you absolutely have to provide is about all that they pay, you'll really want to make sure that you're thinking about the fact that this is retrospective in application, retrospective in nature. Now, rate of pay is probably one of the second easiest to use because it isn't retrospective. It uses the amount that the employee's rate of pay is for that month times 130 hours, regardless of how many hours they actually work. So if you say, okay, our lowest paid employee makes $10 an hour times 130, we just have to make sure that our cost of coverage is below that particular calculation. And I think on the next slide, I actually have that specific example. So I'll go through that in a moment. Federal poverty level is by far the easiest to use because it doesn't base it on the employee's wages. It bases it on the federal poverty level set for that year. So for 2023, we know that federal poverty level is 14,580. So we simply multiply 14,000 times 8.39% and then divide by 12 to make sure that our cost of coverage doesn't exceed $101.94 for a January 1st plan year. So if your coverage is $80 per month for your lowest cost plan, even if they take a higher plan, a buy-up plan, we're just looking at the self-only portion for the lowest cost plan. So you would know, okay, if our coverage costs these individuals $80 per month, even if they take the higher, more rich plan, then you would just simply use that $80 for your ACA reporting, and therefore the coverage is affordable. So that one is the easiest to use, but it yields usually the highest, I would say, contribution for the employer to have to pay. So let's take a look at an example of rate of pay, because this is probably the most commonly used. So for example, in the 2024 plan year, an employer is going to use the rate of pay safe harbor to set premium amounts for full-time employees and their coverage. The lowest paid employee makes $10 per hour. And we use the lowest paid employee because if we know that our lowest paid employees' contributions is affordable, then anybody making more than that would be automatically affordable. So that's why we want to use the lowest paid person to do this calculation. It has to be this calculation. It can't be any other sort of method that you come up with. So the lowest paid employee, again, makes $10 per hour. To use the rate of pay safe harbor, the employer must use 130 hours per month times $10 an hour. Again, 130 is what you must use. You do not use the employee's actual hours worked. That gives you $1,300 per month. Because the affordability threshold in 2024 is 8.39, you would say that the monthly premium cost cannot exceed 8.39% of $1,300. Again, the monthly wages, so to speak, which is $109.07 per month. So this lets an employer get away with a little bit more of an employee contribution because, again, federal poverty level says it can't exceed $101.94. So rate of pay would be your next best option if you wanted to tack on an additional $5 if you have somebody actually making that low of a salary or that low of an hourly wage. In 2023, so let's say you renew December 1st, you're going to use 9.12% because we're still in the 2023 plan year, and that would yield, using the same rate of pay, the same method here, that would yield a little bit more in employee contributions of $118.56 per month for the lowest cost plan for self-only coverage. So you want to make sure that you're planning ahead and that this isn't something that you look back at once you've done ACA reporting and say, I think we can use rate of pay. You want to plan for it and make sure that this is set in stone and that you know that the coverage is affordable, and then your ACA forms are going to reflect which safe harbor you used under line 16 where the two codes are placed. So hopefully this is not news to you all. Hopefully this is something you're aware of and familiar with, and this was just a review. But if not, please reach out to us because we need to have a conversation about getting your ACA forms ready to go. So some open enrollment reminders for those on this call today. This is pretty much going to apply to most employers, things that we see again and again that get missed in the flurry of open enrollment season. So make sure to print these slides, make sure to go through this checklist and remind yourself just in case it sort of goes by the wayside in the next few months. So we want to make sure that you notify all of your COBRA participants, including any COBRA participants that are spouses or children, of their open enrollment rights, because those on COBRA get the same rights to make changes during open enrollment that those who are just active employees get. So this can be a surprise for employers because sometimes they get forgotten about. And sometimes you maybe didn't realize that they can elect dental or vision for the first time, even though they didn't elect those things under COBRA previously. So keep that in mind, that they have, in addition to having separate and independent COBRA rights from the employee or the former employee, the spouse and children, they also have the ability to make changes during open enrollment, just as though they were actively working. You also want to, in the same way, notify any FMLA or any other individuals who are on paid or unpaid leave that they are still eligible for the plan and they need to make changes as well. Sometimes they also get forgotten about, and there's a scramble to have to fix a COBRA participant or someone on FMLA after the plan year's begun, and we really cannot be making changes after the plan year has begun. It's prohibited under Section 125 rules. Ensure that, this is something I mentioned before, ensure that no employee who's enrolled in a general purpose health FSA or HRA also opens and contributes to a health savings account, including the spouse's or parents' FSA. They can have a limited purpose or post-deductible FSA, very common, that maybe only pays for dental or vision, or it only pays for benefits after that minimum deductible. But otherwise, any sort of disqualifying coverage, they should not be enrolling in because it's going to disqualify them from making HSA contributions, which can be a big shock to individuals who have been contributing for many months. So make sure that you're on top of that. Obtain your employee pre-tax elections in writing. This is a good practice, not only for Section 125 rules and the pre-tax nature of benefits, but also for ACA. You want to have a record of someone's offer of coverage, and if they waive coverage and you can get a signed waiver, that's even better for any defense against an employer mandate penalty every single year. Also distribute required open enrollment notices such as the SBC, Summary Benefits and Coverage, Medicare Part D notices we mentioned before, CHIP, HIPAA special enrollments, the Women's Health and Cancer Rights Act notice or WICRA annual notice, HIPAA and EEOC wellness program notices. Also, if you're going to require proof of dependent status, then you will want to ask for, amongst the different types of dependents, you'll want to ask for either an employee attestation that this is in fact their dependent, mostly for tax reasons, or the same, if you're going to ask for more, for example, marriage license, birth certificate, tax return, utility statement, that you ask for the same level of dependent proof across all types of dependents. So we don't want to just ask for marriage certificates for individuals who are legally married. We want to also ask for any sort of proof like that for domestic partners, if you allow domestic partners to be covered, or for children, or any type of dependence. It needs to be the same level of dependent proof, in other words. And so some key takeaways for you all for your upcoming open enrollment planning. Again, pay attention to the upcoming requirements from those transparency and CAA rules, namely the gag clause prohibition compliance attestation that's due to CMS no later than December 31st. Find out where your carriers are going to assist, and if you have to do any submissions yourself, A lot of you will have to do submissions yourself. So please do not go on default. Make sure that you understand so that you can plan accordingly. We still have plenty of time. Consider new limits for your high deductible health plans and HSA contributions. Distribute your Medicare Part D credible or non-credible coverage notices to all plan participants before October 15th, so in the next few weeks. And if you are an applicable large employer, if you're not sure if you're an applicable large employer, attend our next webinar. But make sure that your contributions for 2024 are in fact affordable, taking the time to assess whether you're using rate of pay, W-2, or federal poverty level, and setting that before you go ahead and proceed with your employer contributions for the year. And so here's some resources. And if you have any questions, please go ahead and type them into the chat so we can answer them. And we'll have a little bit of time left for any questions specific to things we talked about today, or even things that you may be wondering about that we didn't get to cover on today's webinar. But we have many resources. Benacurve has many resources to assist you with meeting your particular obligations, all of these obligations. And if you are interested in going through a compliance checkup, please let Alyssa know that you would like to go through a checkup, and we can assess to see if that is a fit for you to examine all of your compliance responsibilities. We also provide regular newsletters and alerts, staying on top of these requirements, sending you reminders, sending you samples, all of these different things we provide you with. So please make sure to read our materials and read them thoroughly, and let us know if you have questions about them. And for Benacurve clients, we have been working diligently with the TPAs that we work with the various vendors and carriers that we work with, to understand specifically with these new CAA requirements, how they're going to assist and what you might need to be doing. So overall, we would love to work with you and help you get your hands around those types of requirements, because they are so new and there are not any shortage of new requirements coming down the pike. So we want to make sure that you're with us and we are able to help you all year round, not just at open enrollment. So contact your account manager, contact us for any additional assistance or other questions you may have. And I'm not seeing any additional questions coming through the chat. I see a couple of folks saying that this was helpful. I really hope it was. So Alyssa, I'm going to go ahead and turn it back over to you just to finish up and see if you have any other additional questions.
Yeah, I'm not seeing any questions either. So I'm going to assume that Sarah covered everything. So thank you so much, Sarah, for today and speaking on compliance and open enrollment. As we wrap up, I just wanted to touch quickly on the four main areas Benacurve supports clients and how we derive these topics for our webinars. So those being product administration, compliance, and our mobile app solution. So if you have any questions in these areas, please feel free to reach out, and I would be happy to schedule a brief meeting to see how we can help. I will also follow up with everyone with an invitation to our next webinar on October 25th on the Secure Act 2.0 with a professional wealth management advisor as our speaker there. So thank you everyone for attending today, and we hope to see you again soon. So have a great rest of your Wednesday.
Thanks everybody. Have a great day.
Bye.